Welcome to this educational program. This module provides an overview of the PSA blood test for prostate conditions. This information is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider or the specifics of your situation. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or to skip through them in any order you wish. The prostate is a chestnut-sized gland situated in the pelvis at the bottom of the urinary bladder, the place where urine is stored. It sits next to the rectum and surrounds a portion of the urethra, the tube that carries urine from the bladder out through the penis. The prostate produces a small amount of thin, milky fluid that nourishes and helps activate sperm cells. An important part of prostate fluid is a protein molecule called PSA, or prostate-specific antigen. This chemical is only produced by the prostate. This substance works to liquefy or break down semen fluid to free up sperm, allowing it to travel to the female egg for fertilization. Some PSA is also released into the bloodstream and can be measured in the blood to give doctors an idea of how active the prostate is. There are three main causes of so-called prostate problems: non-cancerous enlargement of the prostate, called benign prostatic hyperplasia, or BPH, inflammation of the prostate, called prostatitis, and prostate cancer. These conditions are discussed in detail in separate presentations, available through your doctor's office. Ask your doctor if you are concerned about any of them. This slide shows graphically the differences between these most common prostate conditions. Compared to normal, in BPH the prostate is enlarged in size, while in prostatitis the prostate is inflamed and swollen. In prostate cancer, cells can grow uncontrollably to form tumors or nodules within the prostate. So how is the prostate evaluated? Prostate conditions are diagnosed initially by a careful medical interview, including specific questions about urinary function, a physical examination, including the digital rectal exam, or DRE, and lab tests, including urinalysis and the PSA blood test. The digital rectal examination, or DRE, is an invaluable tool to diagnose prostate conditions. In this special examination, a physician inserts a lubricated, gloved finger into the rectum. Because the prostate gland is just in front of the rectum, the doctor can feel for a change in prostate size, shape, or texture, which could suggest the possibility of cancer or other conditions. Although a digital rectal exam may feel a bit uncomfortable, it takes only a few seconds to complete and is entirely safe. As mentioned, PSA is a protein made by the prostate and released into semen fluid and the bloodstream. The test used to detect PSA in the blood is very accurate, and PSA therefore provides an excellent marker to measure the activity of the prostate gland. PSA is used to screen for prostate cancer, and it also has an important role in monitoring men with prostate cancer and other prostate conditions, and for following the effects of treatment. There are some controversies and important issues around the subject of PSA screening, and this should be discussed carefully with your doctor. A rise in PSA tells us that something is happening in the prostate. Unfortunately, it does not tell us exactly what is happening, which is the biggest drawback of the test. A rise in PSA is most likely to be caused by the three common prostate conditions: non-cancerous enlargement, or BPH, inflammation of the prostate, or prostatitis, and prostate cancer. Recent rectal examination or passage of an instrument such as a tube or catheter down the urine channel can also cause PSA to rise, but this is usually not significant and short-lived. Ejaculation may also cause a slight rise in PSA, and it is recommended that one abstain from ejaculation for a couple days prior to the blood test. The main reason for PSA testing is to detect prostate cancer. While it is not perfectly accurate Used in conjunction with the digital rectal examination, it is simply the best test that we have available to detect prostate cancer. As mentioned, it also has an important role in monitoring men with prostate cancer and following the effects of treatment. Prostate cancer screening with PSA is a very controversial topic, and it is important for you to understand the issues involved as best you can, and to be involved with your physician in the decision whether or not to have your PSA tested. The goal of prostate cancer screening is to detect prostate cancer at an early stage before it spreads beyond the prostate. Ideally, like any screening program, it should lead to better health outcome, such as prolonged life expectancy. Also important, however, is that it should avoid over-detecting less important, slow-growing cancer in men who might not be affected by it. Currently, our best simple screening tools are the DRE and the PSA test. The problem with screening for prostate cancer is that this type of cancer can behave quite differently in different men, with some having slow-growing cancer and others having more aggressive cancer. The controversy about screening for prostate cancer revolves around the fact that the tests cannot differentiate between which patients have more significant cancer and which have slow-growing cancer. It is important to understand that if you have a PSA test done and it proves to be abnormal, this can lead to a biopsy, which is a simple but invasive test. You will also need to know that 60 to 70% of these biopsies prove to be negative, depending on the PSA level. Another important fact to understand is that diagnosing prostate cancer by PSA and then biopsy may lead to treatment, such as surgery or radiation. This treatment can affect one's lifestyle by interfering with bladder control and erections. Furthermore, it has also been estimated that anywhere from 10 to 20% or more of men who undergo such treatment may not benefit from it in terms of a longer life expectancy. Finally, you must understand that unfortunately, screening efforts for prostate cancer have not yet proven to save lives by lowering the death rate from prostate cancer. Having said all of this, prostate cancer is a very common condition in men, and it is a common cause of cancer death among men. Furthermore, successful curative treatment does exist. Obviously, it would be a shame to miss out on early detection of an important life-threatening cancer, and many men and many doctors feel that because of this, prostate cancer screening with PSA should be done despite these possible drawbacks. This slide highlights the fact that routine prostate cancer screening is a controversial topic. While some medical bodies endorse screening, others do not. It is generally agreed upon that before entering into a screening program for prostate cancer, men should be aware of all the facts that we have just reviewed, and that they should take an active role in the decision to screen or not. Ultimately then, the decision to screen for prostate cancer is yours, and should be discussed with your doctor. PSA testing is generally recommended for the following purposes: prostate cancer screening, as discussed, to gain further information when a DRE is abnormal, to help choose treatment for an enlarged prostate, and to follow treatment of all prostate conditions. The recommended scheduling of PSA and DRE testing for screening will vary from center to center, doctor to doctor, and patient to patient. In North America, urologists typically recommend annual screening with PSA and DRE for all men aged 50 to about 75, and in the United States, this testing is covered by Medicare. A newer approach is to do a first screening PSA at 40 years old. If that value is normal, then another can be done at 45. And if that value is normal, then regular testing every other year can begin at age 50. The frequency of PSA testing would increase with any abnormal value. All men with a family history of prostate cancer should probably have more frequent testing done, usually annually beginning at 40 years old. A cutoff age of about 75 years old is now chosen as an upper limit, but is not fixed in stone. When to stop PSA testing will vary between individuals, depending on other health issues. Any man being screened for prostate cancer should have a life expectancy of at least 10 years. Because prostate cancer can be slow-growing, the value of PSA testing goes down in older men, as the importance of early detection of prostate cancer lessens. So what is a normal PSA value? PSA is measured in lab units called nanograms per milliliter, reflecting the amount, or number of nanograms, of PSA in a milliliter of blood. It used to be that a strict upper limit of 4 nanograms per milliliter was used for all men having their PSA tested. However, prostate cancer can be found in men with a PSA of less than 4, and 70% of men with a PSA above 4 did not have prostate cancer. Presently, many doctors are now using the following ranges, with some variation. 0 to 2.5 nanograms per mil is low. 2.6 to 10 nanograms per mil is slightly to moderately elevated. 10 to 19.9 is moderately elevated. And 20 nanograms per mil or more is significantly elevated. In reality, there is no specific normal or abnormal PSA level, as every man will be different. Clearly, however, the higher a man's PSA level, the more likely it is that cancer is present, and a steadily rising PSA is most concerning. A variety of factors can cause PSA levels to fluctuate over time, and one single abnormal PSA test does not necessarily indicate a need for further investigation. Researchers have strived to improve PSA testing to reduce the number of unnecessary biopsies performed. Methods in current use include age-adjusted ranges and so-called PSA velocity, free PSA, and PSA density. In the future, other forms of PSA may be measurable and have greater value than our current test. Studies have shown that because most men's prostates grow larger with age, their expected normal value for PSA increases with age, and so-called age-adjusted PSA values have been published, as shown here. These numbers differ slightly by race as well. These age-adjusted ranges have become widely used, as they are helpful in narrowing down who might require a biopsy to rule out prostate cancer. Compared to a single cutoff value, they allow doctors to be more accurate at picking up prostate cancer in younger men, while less likely to unnecessarily biopsy an older man. PSA velocity is the rate at which PSA is rising with time. In general, a slow, steady rise is more likely to be due to non-cancerous enlargement, or BPH, while a rapid rise is more likely to be due to prostate cancer. The cutoff value that is most widely used is 0.75 nanograms per mil per year. In other words, if your PSA is rising more than 0.75 points per year, with at least 3 measurements taken, then your doctor may be more suspicious of prostate cancer and more likely to suggest a biopsy. It is important to know that PSA levels fluctuate in men with normal, healthy prostates. The PSA velocity is only a guide. In recent years, improvement in laboratory testing has allowed for the measurement of 2 forms of PSA in the bloodstream. So-called free PSA is that PSA which is floating freely in the bloodstream, while most PSA is actually bound onto another protein molecule. There are 2 such protein molecules that PSA can bind to, called anti-chymotrypsin, or ACT, and alpha-macroglobulin, or AMG. The usual PSA blood test measures the levels of free and bound PSA in the blood. PSA from prostate cancer cells tends to be more sticky than PSA from non-cancerous cells, so it is more likely to bind to these other molecules. As a result, in prostate cancer, the percentage amount of free PSA goes down. Cutoff values vary. However, typical recommendations are that if less than 10% of PSA is free, then prostate cancer is more likely, while if more than 25% is free, then prostate cancer is unlikely. Unfortunately, many values fall in between these 2 cutoffs, so in these men, we are no further ahead. This test is not available at all centers, and its use is not supported by all doctors, because the cutoff values are not clearly defined enough to rule in or rule out prostate cancer. The test does, however, hold promise for the future that it may prevent unnecessary biopsies in some men. PSA density compares PSA value to the size of the prostate on ultrasound. Higher values of PSA density suggest cancer. This test may hold value for helping to sort out the significance of lower, mildly elevated PSA levels. The major drawback of the test is that it is not practical because it requires transrectal ultrasound. Furthermore, the measurement of prostate size is quite variable, and the best cutoff numbers to use are still not known. If your PSA has been tested and has come back elevated, you will likely meet with your doctor first to discuss it. If not done already, you'll be asked about urinary and other symptoms to rule out obvious causes of the rise. And a rectal examination of the prostate will be performed. Often, a urine test is done to rule out infection or the presence of blood in the urine, and the PSA may be repeated to confirm the result. At some point, you will likely be referred to a urologist, who is a surgeon specializing in the genitourinary tract. The interview and exam will be repeated, and if felt necessary, a biopsy of the prostate may be requested. Prostate biopsy is discussed in detail in a separate module. Many men would like to know what the chances are that they have prostate cancer if their DRE or PSA are abnormal. Statistically, as you can see on this chart, there is still a greater chance that your biopsy will not be positive despite an abnormal DRE or PSA. However, every individual situation is different. It is also important to point out that prostate cancer can exist with a normal DRE or PSA. In summary, the prostate is a small organ surrounding the urinary channel that plays a role in urine control and fertility. Conditions affecting the prostate can cause urinary symptoms. However, prostate cancer is usually detected before any symptoms appear. The prostate is first evaluated by digital rectal exam and the PSA blood test, which is the most sensitive tool available for detecting the presence of prostate cancer before symptoms appear. The PSA blood test measures the activity of the prostate gland. Elevation of PSA is a sensitive marker of prostate conditions, but does not specify the cause. Further testing, including biopsy, is required to rule out cancer in these situations. The goal of PSA testing is early detection of prostate cancer while it is curable. These are some of many resources available where you can find more information about PSA and prostate cancer. This slide lists some of the hundreds of references in the medical literature which discuss PSA. These were used to assist in preparing this presentation, and they are available through your local medical library or the internet if you would like to do further reading on this subject. We sincerely hope that this module has furthered your understanding of the PSA blood test. We wish you the best for the future, and thank you once again for viewing this educational program.